All right. Welcome back to the Life on Purpose podcast, where today I have Dr. Andrew Pope from Kansas Regenerative Medicine and BlueFire Med in Manhattan, Kansas. My doctor for a stem cell treatment that I did recently that I know you all kind of wanted to hear about anyway. So I figured, why not? We'll just bring him on and we'll talk about it. So we'll talk about my story. We'll talk about stem cells. We'll talk about some other work that he's doing, and we'll kind of see where this goes. So welcome, Dr. Pope.
Yeah, thank you for having me. I appreciate the chance
Absolutely.
to educate people and talk about what I do.
Absolutely. And you know what I found was really interesting is, I've kind of been knowledgeable about this kind of world of stem cells because this is my second treatment in the last 5.5 years, for a little while, but I find that a lot of people don't really know a whole lot about it or feel that there's maybe a stigma behind it. So I thought maybe we could clear some of that up. But why don't you tell me? We'll just start with Kansas Regenerative Medicine and stem cell therapy. What is it, and what can you tell us?
Well, yeah. How do I rein that in? So basically, at Kansas Regenerative Medicine, we offer adult stem cell therapy. Okay, and we predominantly will pull it out of the adipose tissue. I don't want to lose everybody and get lost in the details, but a stem cell is not a stem cell. There are different types, different tissues from which they can be acquired. So we focus more on the fat-derived approach. I was trained to do bone marrow-derived, but there are some limitations, nuances between the two. If I was going to sum it up and just be brief, I would say we predominantly do fat because more and more research shows it is superior. Dose matters. And so the fat will give you the highest dose of mesenchymal stem cells that you can get. And so when you're trying to help patients, whether it be orthopedic, such as arthritis, autoimmune, such as thyroid issues, or other autoimmune and neurologic issues, the rate limiting step is the concentration of cells.
Right.
So you want to do the therapy in a way to maximize that concentration or that dose. And so with fat, you get the highest concentration or yield. Now, there's other ways to up the yield, so to speak, if you were able to cryobank and grow them out. That's kind of a good equalizer. That way you can get as many as you want based on the research that shows you need a certain dose for a certain problem. But at Kansas Regenerative, we primarily focus on fat-derived. We also do a lot of PRP regenerative stuff for orthopedic issues as well. We've been at it for 10 years, I think 4,000 plus patients. And, we're still here. So that means we're getting results.
Right. And I think that it's fascinating too. And I talk to anybody, who has kind of the orthopedic issues or autoimmune issues. I have clients of mine that I work with in the health space that I've recommended, going that route or at least looking into that route because of the success that I feel like I've had with it. And it's not something that many people are talking about. So do you think that the holdout or the reason that it's not really out there all that much is because it's not FDA approved and the cost? What do you see? Okay, why don't you start here? How does it work for, say, autoimmune? Let's talk about me. I have, autoimmune issues, autoimmune thyroid disease. I tend to go hyperthyroid. I have insomnia, heart palpitations, joint pain, hair shedding. My vision goes wonky every time, things kind of go out of whack. I could go on and on. So how do stem cells help someone like me?
Yeah, in general, it depends on the condition you're treating as to specifically which pathway and how do those cells kind of derive that benefit. If you look at it from a 30,000-foot view and just step back, what they've done is a body of research where they look at different clinical conditions and you look at efficacy and safety. First, you want to prove safety with this, kind of a proof of concept, show it's safe, and then let's treat some different conditions. So say autoimmune, and to be more specific, say thyroiditis. What you'll do is enroll those patients in that trial. You'll treat them, and then you'll follow them over a period of time, and you'll measure their antibodies, as you know, with certain types of thyroiditis, they get elevated antibodies of a specific type. But then you also follow their clinical symptoms and you try to control that versus a placebo group that maybe has, we already know, that you want a placebo group, a control group, so you can compare and contrast and see what effect was there. Well, what they've seen when they follow these patients that were treated with stem cells is that there are a number that will have what we call efficacy. Okay. And that means their antibodies go down, their physical symptoms improve. They had noted benefit at the end of the day in a measured fashion.
Right.
So they go back and then you try to find out this, you have to reverse engineer it. You get your result. Now you got to figure out, okay, here's the result. How did those cells accomplish that feat? What pathway?
Right.
And with the current body of literature, that's where they're at. They're trying to figure out, how do the stem cells know how to do these things? What cell receptor, what protein, what enzyme, what pathway was triggered? But every time you isolate one receptor, then you open up 3 more questions about, okay, what does that receptor do? And how do these cells know what they're doing? And you can go down a rabbit hole really quick. And that's what's so fun about the research with this, because every question you answer, you open up five more questions that lead to other benefits. So right now at most of the medical conferences, it doesn't matter, neurologic, autoimmune, endocrine, orthopedic, guess what? Most of them are having multiple lectures on stem cell research and all the different positive benefits. So there is an immunomodulatory benefit to answer your question about from an autoimmune standpoint. The research has shown that the stem cells, the specific way we do it, because like I said, it's not apples to apples.
Right.
The way we do it, the fat derived, there's an immunomodulatory benefit. That's a really fancy medical way of saying it calms down that autoimmune fire, reduces the inflammation, and you have a cell type, a plasma, an antibody, something that's causing this reaction. The cells have been shown to ameliorate that or decrease that for a period of time. Is a one-time treatment a cure? Probably not. But is a one-time treatment enough to give a patient years of relief? Well, yeah, that's what the studies are showing. And in fact, your experience is consistent with that.
Right.
So you look at what we accept as standard. The FDA will approve this treatment, that therapy, and they have to scare you with a big long list of horrible things that may happen and at a steep cost. And we accept it because, oh, well, it's accepted and we don't even bat an eye at it. And we'll let our insurance fork over however many thousands of dollars for some of these biologics and things with serious consequences when things go wrong.
Absolutely. I will say, sorry to interject, that this felt, while it wasn't approved, I did a massive amount of reading and I had actually talked to people who had had the treatments in the past. And I felt more comfortable with this, knowing it was my own cells, than I had with any other options that were thrown at me when I first got sick. So, and my first treatment was March of 2018, I believe it was. And I had relief for 5 years until I got COVID, and it kind of flared everything back up, and it was something that I couldn't get under control again. But can you talk about how long, you touched on it just a little bit, how long we can see these treatments, and it may be kind of ailment specific, but how long of relief are you seeing in some of your patients?
Well, you hit the nail on the head when you said it's ailment specific. I have to talk in generalizations.
Sure.
I do my best to look at imaging and the labs and the evidence out there. You can get a feel for a range, a time range, but there's a lot of variables. And some of those variables are on the patient. What's their activity, their diet, their lifestyle, and there's some intangibles that go into that. In general, what we find is that for orthopedic and honestly, the autoimmune stuff, it's years of relief. And I usually tell patients who are good candidates, we look at their background and feel like, yeah, this is reasonable. Let's do this. They should expect a 3 to 5 year benefit out of it. But again, I'm painting a really broad stroke. So there's different degrees of arthritis and wear and tear. The less damage you have, hopefully the longer it lasts when we treat you. The more damage you have, diminishing returns over time. It really depends on what your goals are. Autoimmune, I'll be honest with you, we've treated some MS patients and they've gotten a lot better and longer results than I ever thought they would when we started doing this. So I've been pleasantly surprised. And so we have a number that once the word gets out in that community
Yeah.
about the benefits, next thing you know, we're getting a lot of phone calls. And
Wow.
that's how we've grown over the last 10 years.
That's amazing. I mean, and the reason I found you is because you're kind of in my backyard, not where I currently live, but where I grew up, and started kind of, poking around that, especially when I got sick. And I personally know people, in that area who have had great success using you for a lot of like joint pain. So let's talk about the process, because my process with the autoimmune was different than like somebody with getting a joint treatment. So can you talk about the processes there? Because I had, the fat derived. So there was the lipo and all that fun stuff, which was the worst part of the whole process. So
Well, what's interesting is just recently we changed we're always looking to do it the best way possible. And we've just changed our lipo procedure. It is now less painful. I would say no pain, and much
wait,
quicker.
after I left like 3 months
Yes,
ago?
after
Oh
you left.
gosh, great.
So now it's quicker and less painful. And
Great.
we're getting really good cell counts on those patients. So there's something to look forward to if you ever have to come back.
I hope not, but
I know, fingers crossed. Let's
yeah.
build on what we started and keep you
Yeah.
away longer.
Yeah.
But no, in general, the procedure, if we're doing autoimmune, the big focus there is IV. Sometimes we do mannitol. That's theoretical. It's supposed to help open up the blood-brain barrier for more neurologic issues, and MS, which also affects the neurologic system. For autoimmune, you want to do a big IV, and that only takes about 3 hours. People will walk in and walk out under their own power. I'm not going to leave you worse than I found you. The lipo right now, let's just say you're my patient right now today. Let's step through it. I'll come into your room, say hi, introduce myself if we haven't already met in person. I'll answer any questions you have, and then I'll get you, when you're ready, on my procedure table. We use sterile technique with everything we do. And so what I'll do is spend probably half my time just using lidocaine to do a local in the area where I'm going to pull those cells from, do that little micro liposuction. Now, let me just stop for a minute, because every time patients hear liposuction, your mind always goes to the worst. So I always tell them, whatever you think you know, don't even let your mind go there. Yeah. Let's say lipo is an NFL football game, or I guess in your case, let's call it a Division I college basketball
there
game.
You
go. What we do is going to be more the equivalent of a junior high, 7th grade, let's have fun basketball game. That's maybe not the best analogy, but you get it.
Right.
I'm doing a microscopic version. I always tell patients it's like an NFL game is major lipo. I'm doing a ballet. So I need about 5 tablespoons of tissue. And so when the lidocaine kicks in, the patients don't feel any pain. And hopefully that was your experience.
Well, I will say the lidocaine was probably the worst part. So the getting numb was probably the worst part of the entire thing. The lipo wasn't a problem. And I actually remember laying there face down, and I'm pretty sure we were talking the entire time. So just having a conversation, it wasn't stressful. It wasn't painful, and it didn't take a whole lot of time either.
No, not at all. And I tell patients, it's a weird massage. Yeah. Because if lidocaine does its job in the area where I'm going to be pulling that tissue from, at that point, it's just a weird back and forth, but there's no discomfort or pain. I tell the patients that, and they always look at me and go, well, that's easy for you to say.
Yeah.
But then when we're done, they always get down and go, well, yeah, you're right. That was a weird massage. But,
yeah. Well, what's interesting, I mean, I was in and out. So I flew in the night before, and I flew out just a couple hours after we were finished. And that's how just, I don't want to say non-invasive, because there's some invasion, but that's how easy it was.
Exactly. And the lipo part takes 30 minutes. And then the hard part's really the waiting, where you hang out in the patient room. Takes us about 2.5 hours to isolate and concentrate those cells.
So what is that process? What are you doing in that time? Because this is something I actually, the first time around, I remember going through and researching and all of that. I don't remember that process. So that time that I'm sitting in there and I'm waiting for those cells to be processed, what is that? What is happening in that process?
So what we do is we take that lipoaspirate that we've got, and we're going to go spin it, centrifuge it down, and it's going to separate by weight, volume, different layers of that tissue. And then we're going to be able to pull off the portion that we need.
Mm-hmm.
And then there's different ways to do the adipose derived. Some are more effective than others. I'll clue you in on a secret. We use the most effective way.
Yeah.
You can mechanically break it down to try to free up those cells. But we also go one step further. We use a little enzyme to help break up the connective tissue.
Mm-hmm.
The analogy here is that tissue that we grabbed is kind of like a grapevine. Okay, we're all familiar with grapes and grapevines.
Yeah.
In this case, we're going to pluck those grapes. That's going to be the fat, the triglycerides. We're going to pluck those grapes and discard those. What we're after is the vine. The vine is where those cells reside. So you have to break up that connective tissue.
Mm-hmm.
That's the vine component. And so we enzymatically, and then we also mechanically break that down to give you the highest concentration of stem cells. And that takes, and we do several washings and we run them through different little filters that separate the cells. So at the end of the day, not the end of the day, at the end of the procedure, when we're ready to deploy the cells, you've got that really rich solution. And the technical name is SVF, stromal vascular fraction. Stroma is connective tissue,
Mm-hmm.
the vascular component, and then that fraction that we're able to pull out of that, the stromal vascular fraction.
And you guys over time have kind of honed this technique, because the first time that I had it over 5 years ago, I think I had 10 cc's, and this time I had 40. I had many more this time than I did the first time around.
Yeah, so we're always trying to do everything we can to give you as many cells as we can.
Mm-hmm.
And so what we've done is we've been able to adjust our processing. So that first 10 cc's is going to be the most concentrated portion. But then what we found out in our network was we could continue to process and wash and capture a few more cells that otherwise would have been discarded,
Mm-hmm.
while excluding the lidocaine and the saline and getting rid of that,
Right.
to make sure you're getting a pure product. And as we felt comfortable enough after studying that we could give you even more cells. It took more volume, but you're coming to get better, and dose matters. So
Yeah.
along those lines, that's what we're trying to do, is give you the highest concentration of cells we can.
Sure. Okay. So next step, those are processed. Now what?
Yeah, so we're probably about 2.5 hours, maybe 3 hours into it at this point, right?
Mm-hmm.
At that point, one of my staff will come into your room and start an IV in your arm. And then if we're doing autoimmune conditions, at that point, you'll get an IV. It'll just be a gravity drip.
Mm-hmm.
It takes about 20 minutes at that point?
It did not take long at all.
Yeah, it goes in pretty quick. It's kind of anticlimactic.
Yeah, it really was. I remember thinking, like, that's it? That's it?
Exactly. You're expecting this big, like, it's a
Yeah.
procedure and medical. And so we all have this fear around it.
Yeah.
And then when the IV's done, at that, it's the take-home stuff. What do you do with that little bruise that we left you with? And that's all it is, as you know. It's a
Yeah.
bruise, and it smarts for a week or so, and then heals up. And then the hard part's the waiting, because you came
Yeah.
for results. And that's really where I have to tell the patients. It's usually 4 to 8 weeks before you get some kind of noticeable benefit.
Yeah.
And the bang for your buck is usually around 4 to 6 months. Now, some people defy the odds, and a couple of days later, a month or two later, they're already well on their way, and others take the full 6 months to get their bang for their buck out of it.
So let's talk about my two experiences. So my first treatment, it was another physician. It was the first one I did was in Manhattan, Kansas, that clinic. The second one I did was in Kansas City, or Overland Park. Was it Overland Park? Okay. And you did that one. So the first time around, I have both Hashimoto's and Graves' disease. I tend to go hyper. My blood work was awful. I was having, again, all of those awful symptoms. I tested my thyroid levels, a full panel, once a month for the next probably 6 months. So I don't remember feeling anything noticeable that first month. However, my blood work had shifted. It was trending better. It was still not great, but it was trending better. Month 2, even better. And I had started feeling, if I remember correctly, more energy, one of the, the weird things is my vision had gotten better because that's one of my symptoms. And then by month 3, everything had normalized. I still had antibodies. They were lower, but my levels were in range and I was feeling pretty good. Into like that first full year, my appearance had changed, meaning like my skin color. I know it sounds strange. My skin color had changed, as in like kind of fresher, not so pale and gaunt, because I was really pale and gaunt. I will say my energy came back. My sleep had gotten a massive amount better. My hair stopped falling out. It had been falling out and shedding, all of those fun things. My vision had changed, all of that. So it took probably, 3 months for the blood work to normalize, but by 6 months, I was feeling pretty good. And I was pretty good, minus a couple flare-ups within the next 5 years, pretty good. And then COVID kind of threw me off. So we are 3 months in, almost 3 months into my second treatment, and I'm on trend for the same thing that happened last time. So my first set of blood work at month 1 showed improvement. I get blood work again next week, and I'm hoping that it'll be the same thing, but I'm having the same results that I did the first time around. So what are you seeing anecdotally, studies, whatever you want to talk about, with other autoimmune patients? It doesn't, whether it's autoimmune thyroid disease, whether it's lupus, whether it's MS, what are you seeing people experiencing in this kind of time frame?
Great question. And I'll answer that in 2 parts. Number one, you've got objective data. So that's things you can measure and follow, right? And so you're a best case. This is one of the ideal situations in which to do stem cell therapy, because you have some labs you can monitor for some real effect. Because in the scientific realm of like literature and research, we want tangible results we can touch, feel, see, and hear that are measurable, reproducible. So the blood work speaks for itself. You're not making that up. That's not placebo.
Right.
That is not the power of positive thinking. Is you had an intervention and you have a specific outcome. The variable was the stem cells, right? So what else would have gotten your blood work better? So that is one of the measures you follow with autoimmune disease. You figure out what are lab values, whether it be an inflammatory marker that may be correlated with that disease, or a specific antibody. Like Hashimoto's, you've got different antibodies you can measure, TPO antibodies. Now you also have, and then on the orthopedic front, there's actually a whole, my saying right now is, how big does a mountain have to be before you call it a mountain? People go, oh, we need more evidence. Well, how many more studies do you need showing efficacy for knee arthritis and hip arthritis? It's like, well, at what point do you go, yeah, okay, it's a mountain? Like when it's bigger than Mount Everest? I mean, for crying out loud. But anyway, they've got actual measurable studies on the orthopedic realm where you look at an MRI afterwards and they actually see thickening of the cartilage. Now, usually with arthritis, you'll see loss of cartilage, wear and tear. You lose that spacing, and that's what leads to the inflammation and pain. So if you actually get to the root of the problem, structurally regenerate some cartilage, which is causing their symptoms. Well, and then you measure that on MRI, it speaks for itself. You can't deny those results. But then you do have the intangibles. So you measure patients' pain scores, you measure their activities of daily living, their functional status, and you already know what your control group is like. You know what their status quo is, and then you can compare those 2 groups. That goes way beyond placebo. There's measurable subjective data there, but it becomes objective when you look at it in that regard. And so a lot of the studies will do objective, measurements. They'll do subjective measurements, and it's all valuable data, and it all lends itself to pointing towards an outcome, an answer. Does this make sense? Is this safe? And I've had everything under the sun. I love it. People come through, we'll inject their joints, we'll do an IV, and next thing you know, I'm not making this up. Now, these are anecdotes, so you have to say at the outset, this could be the positive thinking, this could be placebo. But we've had people come through where they get their shoulders injected, they get an IV dose, And then all of a sudden their dizziness goes away they've struggled with for 10 years.
Yeah.
Figure that one out. We had a pilot, actually, that's exactly what happened. She was dizzy, couldn't really fly anymore, and came for shoulder arthritis, but we did an IV dose. And I forget how many months later, it was 6 or 9. She was like, oh, by the way,
Yeah.
my dizziness completely resolved. There's intangibles here. Would I have told her from the outset, hey, guess what? We're probably going to help your dizziness? No, I would not have said that.
Yeah.
There are certain diagnoses like dizziness that there's 1,001 different causes, so it's really hard to be specific. But I get a lot of those. Oh, by the way, is my vision cleared up, my dizziness resolved.
Yeah, and I do find like, there were things that were happening within that kind of 6 month to a year period where I look back like, oh, I can see better. Cause it was at my very worst. I was squinting all the time. I just like I was sensitive to light and all of that. And that was one of those things that I found was like, whoa, okay, this is great. This is great. This, can I point to it being stem cells? I don't know, but it kind of seems that that's probably what was happening. So it is really fascinating, the whole thing. And I think it's probably very, you can't say that it's going to treat this, that, or the other, obviously, but it has these benefits that you probably don't expect. Right. So, but I will say this. So I wanted to make sure, because my first treatment, I had no idea what to expect. I was in a bad state. I was desperate. I had done enough research to feel comfortable, but I didn't know what to expect. And I don't think I put too high of expectations on it, but I was very pleasantly surprised. However, I wanted to be able to measure something. So again, I did the regular blood work, but this time I wear an Oura ring to track my sleep. So, and it tracks heart rate and heart rate variability and body temperature and all of that. So what I did is I tracked all of that back to, so the past 8 months from COVID to when I was feeling really awful, and then before, right? Because I wanted to know what was happening, because I had changed nothing. Like, why all of a sudden are things really bad again? And I had seen some things in my ring data that said that this was probably what happened to me, right? I was in this hyperinflammatory state from something that was kind of novel, I had never experienced before. And I had an elevated resting heart rate from what it was before to like the 8 months after, all of that. So when I started measuring after this last treatment, and I'm pretty sure, I need to look back, but it was about month 1-ish. My heart rate, my resting heart rate, so during sleep, had finally gone back to what it was before, which is obviously one of those big concerns for me, someone with Graves and hyperthyroid and the heart stuff and all of that. So that was very great. And I've watched it and I've monitored it ever since. And my levels are fantastic. My sleep is great because I was having insomnia, all of those issues, elevated resting heart rate, all of it. So all of that is better than it was before the treatment, and back to what it was, maybe even better than before I got COVID, thank God. But it is one of those things that I like to see, is it this or is it this? I like to kind of know and measure. And it was nice for me to kind of have those things. But anecdotally, there's all these really fun stories, of people in my life that, have had it done that have really, really fascinating results too. So, next question. So do you work with, is this something that would be good? Because this is kind of, my realm, for athletes. Do you work with a lot of athletes? Because there's a lot of wear and tear. So we're talking joint pains, all of that.
When the short answer is it's a no-brainer for athletes, because they're trying to perform at peak levels. And there's a couple different rationales to do stem cells. One, you want to get them back as quick as possible because they need to heal quick and get back on the field. Two, you want them back as good as possible. Right. And so you've already seen several of the pro athletes. If you do a quick Google search and type stem cell therapy in athletes,
Yeah.
all of a sudden you'll see a lot of names and you'll be like, wow, I had no idea.
Yeah.
They're already doing it in most realms.
Mhm.
You know, a lot will dabble with PRP, but there's a lot doing stem cells.
That's great.
You know, and some things you do need surgery on, but even in those situations, they'll actually come in after and do stem cells either during the surgery or after, with the idea of maximizing the recovery time
Recovery. Well, and
as
that's what I
well.
was just going to ask. Can you do it simultaneously? If it is detrimental enough that surgery is necessary, is it something that you can also do stem
Yes.
cells, you know, simultaneous with it so that the healing process is quicker? Because that is the idea, right? Is, you know, regenerating, reducing inflammation, all of that.
Well, you know, not to be too pragmatic about it, but pro athletes, time is money.
Yeah.
And so you're seeing this start to become more and more common, where they may need surgery, may need a scope or a repair, and then they at that time will inject that joint or that affected tissue with stem cells, with the idea of, hey, let's get them back as quick as possible, because we have the athlete and the organization has a vested interest in getting them back out there ASAP.
Right.
So
And
not,
you're right there in Kansas City, and I don't want to call out any teams that might be around that area, but
yeah, I know, right? It's definitely who you know.
yeah,
You kind of, there's a network, and you got to be on the inside of that network to make some of those connections.
to have
We
the
have
edge, sure.
we have treated some athletes,
Yeah. Yeah.
you know, and yeah. Anyway, I'll leave it.
So what kind of, so if we're talking about like joints, cartilage, that kind of stuff, is it the same kind of healing time frame as like an autoimmune condition?
There's some nuances and differences.
Mhm.
In general, I find that the autoimmune stuff usually responds maybe a little bit quicker,
Okay.
because there's usually some systemic symptoms going on.
Mhm.
And you're going to notice the benefits a little bit sooner, because the systemic manifestations of the autoimmune condition, whether it be fatigue or, you know, just that
Yeah.
ability to concentrate, things like that, you'll see bounce back quicker.
Mhm.
Orthopedic, it's pretty consistently in that, you know, they start around that 1 to 2 month range, and then they get where they're going somewhere, you know, around 4 months
Mhm.
on average. It does take longer. I will say neurologic issues. When there's damaged nerve endings, or we've treated some patients with TBI, traumatic brain injury,
Yeah.
even some stroke patients, that takes longer. Nerves take forever. I usually tell them they're in it for the long haul.
Mhm.
And so be patient with it, and you know, we'll see where we get to at the end.
Yeah. Yeah, that's got to be frustrating. So let's talk about the age of the cells, because this was a concern of mine. I was 35
Yeah.
when I had my first treatment. I was 40 when I had my second. How is it different as you get older?
Yeah.
Can it be as successful when I'm 65 as it is when I'm 35?
Well, I don't want to lose everybody in all the scientific details, so let me try to be brief about it. It can be important if you're doing bone marrow derived cells after
Yeah.
age 40, 45. It's not so much the age of the cells, it's really the concentration of the dose. How
Okay.
many cells can you get? That's what makes the biggest, that's the biggest determinant of outcomes.
Okay.
Okay. So to in layperson's terms, if you've got a headache, do you want to take, I don't know, 50 milligrams of Tylenol, or would you rather take 650 milligrams of Tylenol? Which one do you think will get you the results? And so age becomes a factor with bone marrow much sooner, and it's the fact that the numbers decline.
Mm-hmm.
Now, there's a little bit of what we call senescence. That's just a fancy way of saying the cells are old and they're showing their age.
Yeah.
In general, with the way we do it with fat derived cells, you don't really see senescence. It's not as big a player when you look at all the different reasons that may, or different variables that can affect the outcome.
Mm-hmm.
The single biggest variable is the number of cells. So whether it's a 35-year-old or a 75-year-old with the fat drive, or even an 85-year-old, doing it the way we do, I'm able to get enough cells that I can, depending on what we're treating, usually get them results. But do I have to be more careful in a 88-year-old? At that point in your life, what doesn't hurt? And you don't want to spread the cells too thin. So I do have to be judicious about what we're treating. How many cells can I afford to divvy up and spread out? But in general, with the fat drive, I don't see a decline in the cell number until about age 70. And since I didn't touch on this earlier, but it depends on which research you look at. I've seen the lowest number being that fat has a 300-fold higher yield of stem cells than bone marrow. I've seen other research that shows a 2,000-fold higher. The point being is there's a higher yield in the fat. And so since you have a higher dose you're starting with, I don't have to worry about age as much. Bone marrow, not so much. If you have somebody who's 60, 65 coming in, it's how many aspirations you're going to do. And that's somewhat painful. And if you're not able to culture and grow those cells, you're going to run into limitations. Real quick, I get a lot of people, there's the umbilical cord, right? So
this is why it's controversial. Sure.
I know. So I don't want to be long-winded, so I'll keep it at this. What we do is we only use your own stem cells.
Right.
Okay. So there's no real moral or ethical dilemma with that. They're easy to get. And the studies show that you can get results with your own stem cells. Right. Because people, they kind of want to correlate. They say, well, I'm 70 and I've got a worn out knee. It doesn't make sense that you can grab my old stem cells and fix this old knee. Why would I have this worn out knee if I had these stem cells that can help me? The issue briefly is the cells are in your bone marrow, they're in your fat. They have no idea that you've got a worn out knee. So they don't jump out, go migrate and look for something to do. That's where we come in. I've got to target that tissue that usually doesn't have good blood flow, good blood supply. And so the cells couldn't even get there, even if they were migrating through the bloodstream, because joints are a closed space. Tendons are relatively devoid of a healthy microvasculature, which is why tendinopathies go on forever. But anyway, you go back to umbilical cord. So you'll see a lot of these people that will come out, do these steak dinners. Hey, come learn about your stem cells. And they're trying to sell you stem cells in a bottle. So it's like, hey, you don't need to even have a procedure. It's so simple. We just buy these beautiful cells that came from a baby. They're umbilical cord cells.
Which is totally unethical.
I know, right? And your old cells are too old to get the job done. But the problem is, number one, you're taking somebody else's DNA, somebody else's protein. Now, theoretically, those umbilical cord stem cells are supposed to be non-immunogenic. They're not supposed to stimulate an immune response. Here's the problem. Most of the research that has positive benefits from the umbilical cord, those are fresh cultured samples that are then used. What people buy from their, I don't want to be too generous and call them the doctor that's offering this to them, they're not getting fresh cultured live stem cells. And multiple studies have been done showing oftentimes they're dead cells. Now, you can get some benefit from it if it works for you, but that's, you know what? Those are growth factors. Those stem cells died. So you have no active stem cell guiding that healing, that regeneration. What you have are blind growth factors that may be appropriate or not for that tissue, but nothing targeting anything. So I think of it as really expensive PRP, because PRP is targeting growth factors. They just overpaid for it big time. So to skip to the end, what people don't realize, the stem cell they're after in the umbilical cord cells are called mesenchymal stem cells. Do you know what we're after when we're treating orthopedic patients with bone marrow aspirate? Mesenchymal stem cells. Do you know what we're harvesting out of your adipose tissue? Mesenchymal stem cells. We're after the same stem cell type. So I go back and I say, well, how can I give you the highest concentration? And the benefit is now doing it the way we do out of your own body, I don't have to worry about what possible diseases have you acquired or other issues from cells that were not your own. And I'll end it with this. The other big thing is there's a chain of custody. You've got to get those umbilical cord cells all the way into the office of the provider who's going to give them to you. There have been multiple instances where they were contaminated growing pus that was then injected into the patient's joint. And I think there was a podcast series, I forget the name of it a while back, but it was talking about 12 different ICU patients that ended up in the ICU because they were septic. They had a septic joint and ended up with sepsis from the umbilical cord injections.
This sounds like Frankenstein stuff.
It is. And, here's what I would tell you. I don't want to ramble too long, but one of the other topics people ask is, well, if this is legit and valid, then why is it not FDA approved?
Yeah.
Well, the short answer is this. If you're doing umbilical cord, that is what's called allogenic. It came from someone else and we're giving it to you. Okay. So the FDA has a right to regulate and mitigate that risk and make sure it's done safely and appropriately. There's certain channels in testing that you have to go through to make sure that it's done right and safely. Okay. Now, here's the issue though, with bone marrow derived and fat derived stem cells, you're taking from the person's own cells and you're using it on them. We don't manipulate them. We don't add hormones to them. We're not forcing them to do or be something they wouldn't otherwise naturally become. When I'm doing a stem cell treatment, I'm counting on those cells to do exactly what they're supposed to do. I just need to get them where they can have benefit. So I'll skip to the end. So in that regard, it's not, we're not giving you a drug. We're not doing a medical device. So the FDA, federal drug, and they regulate drugs, they regulate devices. So what would they regulate as far as your cell goes? We argue this is practice of medicine. So if you're a cardiothoracic surgeon, let's say you're getting a bypass graft, they go down and take the saphenous vein out of your calf, they flip it around, and they make a coronary artery out of it. But did you know that that procedure is not FDA approved? And why would it be? It's a surgical procedure within the scope of that physician's training. But they're not using the vein as it was intended. They're actually turning it into an artery and putting it in the heart, which is a completely different area of the body. So there was actually a lawsuit about that. The FDA said, well, we do have the right to regulate this. And CSN, Cell Surgical Network, they fought back and said, no, you don't have the right to regulate and tell a person what they can or can't do with their own cells, as long as you stick within that purview that I talked about, where you take their cells and you don't adulterate them, you don't force them to do.
So there's it's not FDA approved because there's nothing to regulate per se, because it's your own body and you can kind of do whatever you want with it, right? You can do whatever you want with your cells as long as it's not, unethical or whatever. You're not manipulating it in any way.
Exactly. It's scope of medicine. And turns out the judge agreed. There was a lawsuit. This group went up against the FDA, and nobody wins against the government, but apparently they defied the odds. The judge came out and said, no, you absolutely haven't made your case. You haven't proven that that there is risk and that they've manipulated these cells in an unsafe way and forced them to do something they haven't. The judge came out and said, no, you don't have the right to regulate a person's own cells and tell them what they can or can't do with their own cells. So it was pretty surprising. Now the FDA has appealed that. They waited till the last possible day to file their appeal motion, and they filed that appeal, and it's yet to be adjudicated yet as far as the appeal goes. So we'll see how that turns out. So
what would their purpose be in wanting to regulate it if it's not?
Well, you're going to make me go there.
Yes. I'm honestly curious, because this is the kind of stuff that really makes me angry in medicine in general. I've had some really horrible experiences just with my own health and that whole realm, which is why I want to get into what you're also doing separately in your other clinic. But why?
Okay. Can I answer it in two parts? I'm gonna you got an angel on your shoulder and a devil on your shoulder. So the angel on the shoulder would say this: the FDA has a vested interest in making sure that the American public is not unnecessarily put at risk, and they feel that they are the appropriate body to regulate and hold people to certain standards and accountabilities when it comes to stem cell therapy. Okay, so they want to look out for the public. That's the angel viewpoint. The devil's viewpoint would be this. Oh boy, this is just an opinion. So this is disruptive. Okay, you cannot put a patent on brandy stem cells. No one can monetize your cells, put a patent on it, get exclusive rights to use it, deliver it. So they can't monetize it.
Sure.
So it's done in the practice or medical, a physician's clinic such as my own, and no one else can monetize that. So let's say it works for orthopedic issues. Orthopedic osteoarthritis, the industry is a multi-billion-dollar industry. Every year we spend billions on pills, injections, surgeries, devices. So there is, I have to be careful. But if you look at the leadership in the FDA, there's, it's almost an incestuous relationship with big pharma and pharmaceutical companies.
I think we've all learned this through COVID. Yes.
Yeah, yeah. And they don't always, I think the American public before COVID traditionally assumed that the FDA was always looking out for them.
Right.
Altruistic, they're just doing what's right for us. It's all just this moral imperative to, well, what you saw was that's not, there's a lot of politics, a lot of ideologies, agendas, and there's a lot of pay to play.
A lot of money.
Oh, there's a ton of money that goes into this. And so when you do stem cell therapy and you kind of circumvent all that and you help the patient, and all the big players with the big dollars and the big donors and the lobbyists see this, it's a threat. It is absolutely a threat to the status quo of the way they generate money. Now, I don't want to sound like a conspiracy theorist. I'm just saying that there are always incentives, and some we're aware of, some we're not. These things I've mentioned are all variables that do, I believe, play a role to whatever degree. And so that's where I'll hedge and say, to what degree, I don't know.
Yeah.
My argument is this. The FDA is not set up, I think, right now to regulate effectively stem cells. Because what am I supposed to do? Batch, like when you do Tylenol, you can come in, FDA can regulate my facility, make sure I'm producing Tylenol at the right milligram per tablet with minimal contamination or impurities, and it's safe to give in that regard. And you can measure that and test that. But Brandy, your cells are different than mine. Right. Okay, so in a surgical procedure, really the only thing you can regulate is, am I using sterile technique? And is the procedure that I'm employing to concentrate your stem cells, is there science and evidence that shows you can actually give a concentrated form of stem cells? Right. Are they alive? Are they your stem cells? And that evidence has been out there, is out there. I'll skip to the end. We actually had a meeting with the FDA in 2018. We pulled some strings. We were able to get a sit down. I just leave names out of it. We showed up, and our goal was this. We wanted to see, what are you wanting? We naively assumed you are interested in helping patients get better. It makes sense that we have research and evidence that stem cell therapy, regenerating cartilage, helping autoimmune disease. How can you deny these results? And the safety evidence is there. So logically, you think you would sit down and say, the evidence shows it helps, it works, it's been reproduced, and that the hallmark of science, reproducibility with different studies and research. How many more do we need? So I thought they would acknowledge that and tell us, well, here's what you need so we can work together. Long story short, they're like, well, put a study together for, let's say, the joint, and do a before and after showing you, your clinic, Dr. Pope, and how you process the cells, and then follow those patients with a control, and then do a big study over 2 or 3 years, send us all that data. Well, let me tell you what, to just do that study, you're looking at $1 million+. Who's going to fund that? We're a small little clinic. So you've just cut all the small guys out. And if the results show what the research, points to, that, yeah, they're going to get better statistically, it's going to help pain functional scores, all this. Well, guess what? All they're going to do then is approve my clinic and me to do that specific procedure the way we did it in the research for that specific joint. But with the fat, I get more cells than I need to treat just a knee. So if I say, well, what if I want to do your hip? Yeah. Oh, no. The FDA says now you have to do another $1 million+ $2 million trial and show the outcome on the hip. Well, what about thyroiditis? Oh, you got to do another trial. So I have to do a specific.
So it's millions upon millions upon millions upon millions of dollars to do these individualized studies when they're really just choking you out of individualized medicine, regulated individualized medicine.
Yeah. And what was lost on me is I thought, well, if you're really looking out to make sure we're in the best interest of the patient and we want to minimize snake oil, minimize the charlatans out there, because there are some. Yeah. I mean, there are some bad actors that make us all look bad. Absolutely. Yes. And so there needs to be somebody regulating, some standards, someone holding people to account in what they're saying. I don't disagree with that at all, but there's got to be a middle ground.
Sure.
What surprised me is the FDA. It's like, well, figure out a pathway, understand the limitations and nuances and the challenges that we have, and let's figure out a way for small clinics. For example, I believe in Japan a few years ago, they saw the early research on stem cells and they created a registry. So you could do stem cell therapy, skip straight to phase 4 trials, and you just had to track the patients and adverse events and outcomes in this registry.
So it was
That's
a more broad trial here, a more broad spectrum of what they were looking for to try to regulate it.
Yeah. And so the argument is, why don't you work with small clinics that don't have billions of dollars in the bank to fund all this? How can we move forward? How can we get this done? Treating patients, without bankrupting the clinic. And I'm like, you know what you're doing when you set these precedents and these requirements out, you make it impossible for us to practice. And then you go back to the conspiracy side and say, now I know you're not that dumb.
Yeah. Right.
You know what you're doing, and you're squeezing the little man out of the picture, but you're harming the patients. And I'll wrap it up with this. I tried to make the moral imperative argument with them. I said, I've seen the research, I've seen the evidence, I've treated patients. This is life-changing. It can help. There's literally no downside using your own cells. Worst case scenario, you don't get any bang for the buck out of it. I'm like, so if I have a therapy that can help patients with hardly any downside other than the financial risk, do I not have a moral obligation to give that patient the choice to have this done if it's appropriate? It's one more option when a lot of times, what are we considering for some of these autoimmune diseases?
Right.
$10,000 a month meds that shut down their immune system and cause other problems, increased risk of infections, increased risk of cancers, and all these horrible things. And here I've got a therapy that has been shown to help them with no downside. And I was like, how can you I sort of was trying to tell them, like, you're actively harming patients by
absolutely. And you're also, I feel like on the patient side of it, we have a right to try, right? So even though just because there's not this FDA approval slapped on there, that's kind of where I was at when I was, at my worst of, after I had done all the reading and the research. Well, I have a right to try this, even though there is no FDA approval, whatever. It's my own cells. I will do whatever I possibly can. And your clinic was top notch. It still is. First time, second time, there's nothing that's changed there. And I felt like it was kind of the first time in my path that someone was actively trying to help. Does that make sense? Like, it didn't feel like some ploy, some game. And I think I've spent the last, since 2016, probably when I got sick until this day, finding practitioners that operated at that level for me, where I knew that this wasn't about anything other than helping people. And I've been able to do that. I have practitioners in my life that I feel wholeheartedly are like that. And I'm very appreciative of it. And I do feel like it's trending that way somewhat. We're not there yet, but I do feel like it's, we're to a point now where patients are pissed, doctors are pissed, and something has to change, right? Like, it's got to hit rock bottom before it gets better, but something has to change. Going to start moving away from, this almighty regulatory system and doing what's in the best interest of people in general. And I think that's where you're at, in the other facet of the work that you do with BlueFire Med, right? Which is a subscription-based model of medicine. Is that right? Is that a good description of what you're doing?
Yeah, I don't want to get copyrighted here, but I always call it the Netflix of medicine. That helps patients understand it. You just pay the monthly fee and you get unlimited access. We just take care of you. No more nickel and diamond.
Cut out the insurance.
exactly.
We're not dealing with all of that. And then it frees you up to treat your patients the way they need to be treated. So tell me, we might wrap up, with
Yeah.
some more stem cell stuff, but I think this is a good segue into that.
Yes.
Where were you? Why did you decide to get out of that traditional treatment model and do what you're doing now?
I'll spare you the life story here, but background is, I've always wanted to be a doctor, and I naively thought it would be this helping people in their time of need. If I could heal, I wanted to heal, and if there was bad news to be given, I wanted to be the one to give it, because I had encountered people that had no bedside manner, didn't know how to deliver news, and just people in their time of grief and need. You can still be a healer.
Yeah.
And that's what drew me to medicine. And so when I went through med school and training, I had this Marcus Welby notion, Norman Rockwell idea of medicine. And that, wow, the machine, man.
At what point did that crumble for you?
Probably my first year of residency, it was a dose of reality. It's, there's a hierarchy. And when we're in residency, taking care of patients, we were made to felt and honestly told that you're lower than the janitor here in the hospital on the totem pole. And just the brutal grind of medicine. And then you get out in the real world and you start practicing in private practice, which I did. Then I had to deal with insurance, and they don't really equip you with that side of, you're focused on medicine. There's so much to learn about the human body. You're singularly focused on that training all through med school and all those hours. So you get out and now you're like, whoa, what's this whole apparatus about how to deliver medicine in this healthcare industry? That's being a generous way to describe it. They treat patients like they're widgets on an assembly line, and they come at it from their MBA, profit loss. But the problem is we're dealing with human beings, and they're not widgets. So it takes what it takes to take care of those patients. Without going into it too long, there's a lot of challenges. So the system knows how to monetize procedures really well. You can figure out the time, what's involved, and all that. What they can't monetize is the thought quotient. So if you spend an hour with me and I go over 4 different things, 8 different things, fill in the blank. Insurance isn't going to pay me for that, because there's not an easy way to, here's the code for a toenail removal, whatever.
Sure.
So they don't monetize for it. And so let me skip to the end. Overhead has gone through the roof. When I was in private practice, my overhead was 70%. I had to see on average about 22 to 24 patients a day just to break even. Only after that was I able to put food on the table. So you wonder why things have gotten so busy. The analogy is, you look at healthcare as a pie. Well, the pie is getting divvied up. Used to be it was the patient, it was the doctor, and then maybe some office staff. But now you have all of these mid-level administrators. They say, and this may be dated, but they say for every one physician, there's 16 healthcare workers, right?
Yeah.
Only 6 of them are involved directly. Only 6 of them are involved directly in healthcare or with the patient, direct patient contact. The other 10 are purely administrative. So when people ask, why is medicine so expensive? Well, go ask the 10 administrators. We've made this a big, bloated, bureaucratic mess because there's been books written on it, The Moral Hazards of a Third-Party Payer. So we turned insurance not as insurance anymore. We asked them to be a payment processor for everything healthcare related. So we've kind of maybe abused it in a way where then they did it to themselves, because early on they were like, hey, buy some insurance. I'll give you a story. I had a gal in 1956 delivered her baby at Baylor down in Texas. She's a really sweet lady, one of my favorites. She's like my grandma. We schedule like hour visits just so we can do a little bit of medicine and chat. But she came in and brought a receipt one time of her, she delivered a baby via C-section. It was a 3-day hospital stay. And she goes, this was back when they gave you steak meals, steak dinners, and like top notch. And it was a C-section. So it was the surgeon's fee, the hospital fee, the anesthesia fee, the food, the nursery, all of it. It was like $356 for the whole thing. And Yeah, right. I saw that. I'm like, whoa, I made a copy of it and I
Let's go
lost
back to the 50s.
it. I know, right? Well, think about it. So then insurance comes along and says, hey, you know what? You weren't back then, $300-400 was a big deal. So you're like, well, hey, for $10 a month, we can mitigate against that. And then you skip ahead decades. They keep adding more and they were of good value. Well, for an extra dollar, we'll cover you your primary care office visit. For an extra dollar here, well, next,
You
skip to
give
the
an inch, they take a mile. Right. It just kept
exactly.
getting worse.
Well, and then they go to the hospital who maybe used to charge a 10% markup. And they say, hey, well, 80% of your community is on our insurance plan.
Mm-hmm.
We want a 30% write down, or you'll be out of network and your patients can't go there. So then the hospital was like, well, we're only charging a 10% markup. What do we do here? So now you can see how they charging rates. And then they know what the highest payer, the insurance, which insurance company pays us the most. So that's the minimum we need to charge. But here's the secret. Insurance never pays the retail. They get a big write down. But when you call and say, well, I need that price, well, you'll never get the price up front because they're not very transparent, despite the law that was recently passed about transparency. Anyway,
They're still having trouble with that one.
I know it's like, oh, legally you're supposed to tell me what all your prices are, but then I still can't find them anywhere. And the ones I get, you go get your procedure and somehow it's like 3 times more than what their quoted price was. Sure. I've had patients have that happen. But anyway, I digress. I'd go on all day long. Let's get back to why I did DPC. But so I realized that I have no autonomy anymore. Insurance is dictating to me what I have to do. You ever wondered why you go in for a cold or a urinary tract infection or something and they get your BMI and they ask you if you quit smoking and they ask you if you have scatter rugs in your home, stuff like that. They have to, or insurance will say they're not providing quality care and they'll decrease their reimbursements.
Yeah.
So then the doctors get caught in the middle. I was frustrated because I just want to take care of patients, but my overhead was so high. I now had to see so many patients in a day that I couldn't give the way I wanted, the quality care I wanted to my patients. And guess what? I could only afford to have a few open slots in my schedule every day because I couldn't afford to have any of them go empty. So then when you have your doctor and you call the office, well, they're booked up. You can see the mid-level down the hall. Mm-hmm. So do you really have a doctor at that point if you haven't seen them in 3 years because every time you call, you get
placed with someone else?
Exactly. And I think that's unacceptable. And yet, guess what? We've accepted it. It's become the status quo. People should demand more. Mm-hmm. All right, we'll skip to the end. I was frustrated at the lack of autonomy, all the things coming down from the government that were just, there's a lot of big players with a lot of big money. And people always say, well, what if we just change the whole system? I'm like, well, the system's broken, but it's not for somebody. And I'm going to tell you what, that somebody has a seat at the table in DC. So no matter what they come down with, the people getting rich now will still get rich then. They're just going to wrap it up in a different bow, not to be too cynical about it. So I'm a rebel. I was like, all right, I don't like complainers, which I've been doing now for 10 minutes. But no, I don't like, come up with a solution. Okay. If you're going to complain, have a solution to solve the problem. Right. And so I told myself, I don't have a right to complain if I'm not going to do anything about it. And so what do I directly have control over? I said, well, I have control over how I treat my patients. Yeah. And so how can I do that? Well, I had to kick the middleman out. So what I did is created a model. I wasn't the first to do it. It's exploding across the U.S. For obvious reasons. You don't need me to explain. It sells itself.
I will tell you that I saw it a lot during COVID. I saw a lot of subscription-based healthcare pop out of the woodwork during COVID. Yeah. People wanted a certain level of care. They wanted people to listen to them and they wanted options. And I saw a lot of that happen. So you're right. It's not new. And I think but in the last couple, 2-3 years, we've seen a lot more of it.
You're right. And some people can't think out of the box and they're still stuck in that insurance mindset. So they're like, well, for an extra $50 a month, but I'm already spending all this on my health insurance. Yeah. But they always have to step back and say, well, number one, what we do isn't for everybody. Depends on your situation. Sure. But do me a favor. that's a sunk cost for peace of mind.
Yeah.
But what is your copay? What is your co-insurance? And what is your deductible?
Let's do some.
So exactly. So that 50 or 70 bucks a month for membership for me, guess what? You'll never get an office visit charge again. And then you have my expertise and my time, and you can access me via phone, email, telehealth visits, or you can come into the office. It doesn't cost you anything. What I'm going to do is figure out how can I appropriately help meet your needs, and is a phone call appropriate, or do I need to bring you in? It changes the whole paradigm for how you deliver care, because now I'm not worried about capturing that office visit charge. So I'm just going to help you and meet you where you're at. We can do home visits.
Right.
Now, we include a lot of stuff for free too, but I'm also ornery. So we dispense meds at wholesale prices. And I tell the patients, look, I could mark these meds up probably 80%. They'd still be half of what the pharmacy is, but I don't.
So even their meds are cheaper.
Yeah. So what we do as part of that membership, I use my knowledge of how the system works to give them, my motto is do no harm, right? The healing part, do no financial harm. I have an understanding of the workings of the system and access that, they don't, and they don't even know what they don't know, or the right question to ask for how to advocate on their behalf. Right. Well, I kind of take that on. I'm like, all right, I'm going to figure out how to get you cheap labs, which I've done. So now all of a sudden a CBC, a blood count may cost them $1.50. A TSH might cost them $2. An A1C might cost them $3. I can get a vitamin D. Now we don't have to worry about, insurance won't cover it. You're going to get that
vitamin D one is expensive. I've had that one done a couple times.
I think it's either $8 or $11 in my clinic. I always forget. It's amazing. So cheap. Yeah. And it changes the conversation. Now I don't have to say, well, is it covered by insurance? No, you have to have this diagnosis or that for them to cover it. And if they don't, you'll get a surprise bill in the mail 3 months later that you didn't know was coming and you're stuck with. Do you want to just skip all that and pay $11 so we can find out what your vitamin D is?
Well, and I think in this model, you avoid kind of the stress of, I know how much it's going to cost me if I go to the doctor. So I'm going to avoid going to the doctor, and I'm going to just kind of pretend nothing's happening, and I'm going to let things get worse. And, you see a lot of that because nobody wants to kind of go into this financial ruin of a big hospital bill, big doctor bill, big insurance bill, whatever it is. But I think the thing that I find the most fascinating about what you do is that it creates a relationship, right? That's what I want. I want a relationship with my doctor where he knows exactly what my needs are. He knows everything that I've been through. He knows exactly what's going to work, what's not going to work. And if he doesn't, we're going to work to figure it out. That's what I want. I want him to know my kids. I want him to know my husband. I want him to know my family. That's what I want, right? So do you feel like you're able in this model to create relationships with your patients to where they trust you, you trust them, and you know that you're in this together, right? We're going to find answers.
Yeah, absolutely. That's one of the benefits. I've got families that have been with me and they followed me from my private practice insurance fee-for-service model. They followed me over, took a leap of faith with me. And I'll be honest with you, having that time and that relationship where I know them so well, it has improved my ability to deliver care. There are times where we're chatting and the patient has no idea, because they don't have a medical background, that something else going on is related to maybe their symptom. And it was just because of that relationship and that time that I had to chat with them where they say something that all of a sudden
clicks.
Yeah, that's so relevant and that changes this or that. Right. We just found it right there and they had no clue. And if I was in my old practice where I had my 5-10 minutes here and there, or my 15-minute physicals, there's no chance we would have engaged and had the ability to find that answer or that solution. And then trust with your doctor is so important.
Yeah.
I mean, some people are healthy and it's a transaction. No one wants to go to the doctor. I always make a joke with my patients. Hey, the only thing worse than going to the doctor is going to the dentist.
My
Yeah.
stepdad's a dentist.
I love them. But it's kind of like that's the one thing, and maybe it's
Yeah.
just me. I'm like, I'd go to the doctor before I go to the dentist to get chewed on.
We tease him so much. We tease him so much. Nobody wants to go to the dentist.
I know.
So personal story, kind of along those lines.
Yeah.
One of the worst experiences I think I ever had was when I was having all these symptoms. I didn't know at the time that, I was having this autoimmune process. And I kept going to my doctor and saying, there's something up. There's all these symptoms. I'm feeling really off. I'm feeling really off. So because of this process, I had a miscarriage at 12 or 13 weeks. And so it was very unusual. It was my third pregnancy. She didn't know that, right? She hadn't been with me. And so in the 5 minutes we were together, she had said to me, after I had listed all these things, but because she hadn't been able to spend time with me or know me or anything like that, it was, you're just sad. You have generalized anxiety. Here's a pill. Here's some antidepressants. And it was in that moment where it was just so cold, and it was 5 minutes to the point of, you know me so little that, if you did, you would know that that's the furthest thing from what's going on. Right. Yes, I'm sad. Yes, I'm, there's all this sadness around it, but that's my hair's falling out. My joints are on fire. Like, there's all these other things going on. And there was no time to dig into that. None whatsoever. And so, we parted ways, and that was kind of the beginning of me trying to figure out someone who could help me, someone who would listen. Right. And again, I've spent a lot of time over the years creating kind of that team. And I will tell you, my doctor here, he doesn't do a subscription-based model, but he also does not do insurance. So it does cost me. But for the kind of care that I get, I will pay it. But he was the first one to say to me when the second incident happened and I went in and my blood work was awful, to say, I know you did stem cell therapy in the past. Is it a possibility of doing it again? Because he believes in it. He had done enough research. He knew it had worked for me. And he remembered that because we'd spent enough time together over the last how many years talking about it. And it's that kind of care that I think you're talking about, right? It's, your patients, what works for them, and you can dig, you can spend that time.
100%. I mean, that's what you need, because it's a complicated relationship. Patients have certain expectations of the physician, and what we all want is just, isn't there a test or a simple diagnosis so we can find the treatment and the plan? And sometimes there is.
Yeah.
Sometimes they're not. And where you see the system really fail is when you are not the cookie cutter textbook. Oh, this is, hey, test this, do this. When you're, guess what? Human beings are complex last time I checked. So you've got to be able to have the time to dive in. And when you're anything beyond that, that's where you find, not all, a lot of the traditional type of experiences in the fee-for-service system.
Yeah.
Those doctors, you'll feel that distance. You'll feel that gulf. They shut down. They won't listen because you're not an easy case and they don't have time. They don't get paid for it. They're overworked. They're burned out. They're doing charting till 9 p.m. for the patients. And it's just less than fulfilling. And that's the nicest way to say it.
Yeah.
And so, that's really hard. You don't know how many patients I talk to. It's the same thing. It's like, they don't listen to me. It's just, it's a simple transactional thing, but I need someone that will listen.
Connect, right?
You got to work. And that's why I tell patients, I don't always have all the answers. My background and my training is so I can get closer to the bullseye quicker. That's build on my foundation to help figure out what's going on with you. And then we can target and hopefully find a plan that works for you. Can we cure? Do we manage? How can we give you an improved quality of life? What's that look like? And that takes time. You got to know the patient.
Yeah.
But you're not alone. I mean, I hear these stories every day. The system is broken.
So let me ask you this last question. What makes you so different? Because you do, so the clinic, what you've created there, and then working with stem cells, which is also very much out of the box. What makes you so different? Why won't everybody kind of take this leap? How was it like crumbling everything down to rebuild back up? Is it, do people think you're crazy? What is it about you?
Well, real quick. Yeah, honestly, a lot of doctors can't wrap their mind around what we do. Some of my old partners, when I talk
It's
to
the
them,
only thing that makes sense to me.
but that's the problem. It makes too much sense. And you're thinking, if it's so good, well, it's too good to be true. What's the catch?
Yeah.
And my old partners, when I left the practice, I told them, hey, I love you guys. You're doing great and you're doing the best you can in the system on the hamster
But I'm
wheel.
not doing it anymore.
I'm bailing off the hamster wheel.
Yeah.
And they really couldn't wrap their mind around what I was doing. It just, it didn't click or compute. And so the first couple of years, they treated me like, I don't say this lightly, but like a cancer patient.
Yeah.
How are you doing? Are you doing okay?
Oh,
like,
really?
Yeah.
Speaking hushed tones.
The clinic's great. We're growing by leaps and
Remember
bounds.
that, Dr. Pope?
Yeah, no, they're great though. They're great, and I've got a good working relationship with them. But long story short, here's the issue: most doctors, they're trained singularly with one focus, and that's to master the human body, right? Physicians. 4 years of med school, all the training, all the 20,000 clinic hours, all focused on taking care of patients. So when they get out, maybe they had 6 weeks on practice management on how to like navigate the rest of their life. Well, they don't have control anymore. Most of them are out and they're employed. And so they have no autonomy, independence. They're dictated to, hey, Dr. Pope, you need to spend 5 minutes less per patient per day, and you can see an extra 4 patients per day and then boost your RVUs by the end of the quarter, and we could make all kinds of money for the clinic. Doesn't that sound morally disgusting when you're talking about delivering healthcare to human beings?
You've turned them into numbers. Yeah.
Ding, ding, ding. And that's the problem. And that's where we've gone with it. They keep trying to take this business approach and it doesn't work. But when you get back to the doctors, why don't more of them say enough? Well, one, we eat our own. If you look at doctors, different specialties, we can never get together because we're all territorial. That's part of the
what are you saying? There's a lot of egos around medicine?
Oh, yeah, go figure. But on top of that, think about it. You go through all that training and you're going to have $250,000 in debt when you come out. Right?
Yeah.
And then by that time you're starting a family. So you got some car loans, you got a mortgage on your house. Well, okay. So they may hate the hamster wheel and they may be burned out and miserable. And guess what? Physicians have the highest rate of divorce, suicide, and alcoholism. Yeah. I wonder why. But they don't know.
Before dentist or after?
I don't know. I need to compare the data. I need to look at the data. We'll have to ask him. But anyway, the issue is to do what direct primary care is, to go out, it's field of dreams. It's build it and they will come. But the problem is, how are they going to pay the mortgage? How are they going to pay their student debt? How are they going to support their family? So that fear, and they're not business people. That was never taught to them. They're lucky if they can balance a checkbook. They're highly intelligent, but in a very specific, narrow realm. Sure. And so that business acumen isn't there. And so they just don't believe in themselves that they can run a business. They've only ever been taught that you just have to show up and diagnose and treat patients. That's your gift. And so they won't make the leap. They're afraid. How am I going to pay the bills? What if it doesn't work? And you know how we all are. It's the devil you know. Sure. So you stick with the status quo because you're afraid to make the leap. But more and more doctors, like you talked about earlier, it's getting to a breaking point. More and more are jumping off the ship. They're grabbing the life raft, saying there's got to be a better way. Because otherwise, their alternative is to leave medicine. We're going to add a third physician in January. And she approached us and she was about ready to leave. She went through all the training.
Yeah.
She used to be my med aide. I shouldn't say too much. But anyway, she went to med school and she's just a super gal, and she's had a baby or a young child who's about 2 years old. Now she's had a newborn. Yeah. And the demands of what was being dictated to her, for example, I should be careful. This is her story. Well, let's just put it this way. She had to pump, she had to pump for 15 minutes because she's nursing her child.
Oh,
There was no input from her. They didn't ask her. But right after she got back, then they double booked her visits and made her see 2 patients at the same time, because I guess she could split herself in 2 to make up for that last 15 minutes for pumping.
it takes away your humanity.
Yes.
Yeah.
And she was desperate.
Yeah.
She was looking for a life preserver, and she's like, I got to do something. And so she talked to me about what I do. And she's like, I was ready to leave medicine, but this is the first thing that's given me hope that maybe I can do this.
So the
And so,
word is out a little bit.
yes.
So I have a friend here who so she's a dentist who completely crumbled her practice to the ground, flipped it on its head, and completely changed the way that she did things. So she went from the traditional model to doing biological dentistry with kind of preventative care, all kinds of different things. So it's hard, but it's possible if you see something wrong, if you have the guts and the wherewithal to change it, why not? Right. And she's the happiest she's ever been. It was difficult, but
She
she's
had to be
doing something
willing.
different, and she's doing it in the way that she sees is best for her patients. And it's changed. And I mean, she's grown and it's been great. And again, back to my doctor here, he was actually, he still is in emergency medicine, but he started his integrative wellness clinic and does the care that he wants based on what he finds best for his patients, which one of them is me and will be until he leaves or I leave, one or the other. But I guess my fear is that there's not enough of you, because I know now what works best for me and for my family. And that's the kind of care that I want. And I won't compromise from now on, ever again. And
Well,
I hope wherever I land in my life that there are people and doctors out there like you who will continue to do this, and more and more and more and more will follow along.
yeah, the good news is help is on the way because it's just rapidly expanding. I know there's some bills in Congress right now that are actually addressing DPC, making it easier for like HSAs and medical write-offs, and making it the norm to, because that's part of it, to standardize it. And here's what I would say: be the change, and that's what your friend did. We see something wrong. We're just going to sit and be miserable, or are we going to be the change? But then I tell my med students when they come through, one of the things I say is, if you're not uncomfortable, you're not growing, you're not learning. And so, that's something you have to seek out, is say, if you see a problem and I think there's a solution, what are you going to do about it? And will it make you uncomfortable? Will it give you butterflies in the pit of your stomach and keep you up late at night worrying about your future and how to pay the bills and all of that? Absolutely. Yeah. But guess what? Tomorrow will come. You will have food on the table. You will keep the roof over your house if you're a hard worker and you're dedicated. Yeah. You will do what it takes to make your dreams come true. You just got to be willing to pull the trigger and go after it. So anyway, that's my sermon for the day.
I think that's a great note to end on, honestly. I mean, it's been a fascinating conversation. It's exactly what I was hoping for to dive into. And again, I hope people do look up Kansas Regenerative and BlueFire Med and seek out physicians like yourself for that kind of quality care. So I appreciate you very much. And I'll keep you posted on my next blood panel. I'm hoping.
I want to see the lab results. I want to get that in the database.
Yeah, absolutely. I'll compile them and we'll chat for sure. So Dr. Pope, it's been an absolute pleasure. Thank you so much.
Likewise. Thanks for having me on. I appreciate it.